Hello everyone, welcome to Unacademy. Let's crack NEET PG. I am Dr. Shilpa Dinesh. I'm a practicing pediatric consultant and an educator in Unacademy. I have an experience of teaching undergraduate and postgraduate medical students. I have done my MBBS and MD from Rajiv Gandhi University of Health Sciences. So today we'll be discussing about neonatal cholestasis in detail. So as you all know, neonatal cholestasis is a very important topic for pediatrics and a lot of questions do come for your NEET PG entrance, okay, from this topic. So today we'll have a very in detail discussion on this topic. Okay, so before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform, and there are a lot of benefits you can avail from this platform. So, firstly, the daily live classes. There are various educators in this platform, and they have classes happening regularly. There's regular live classes happening in the YouTube platform, the special subscription platform as well. So you can attend your favorite educator's class, engage in discussions, ask your doubts, and all these doubts will be cleared immediately in the live chat box. Also, coming to the structured course. So once you're structured course meaning whenever you're preparing for your entrance exam, you need to have a structured approach. You need to plan really well for your entrance exam so that by the time you give your exams, you would have been revised really well. So here in Unacademy, all our courses are structured in line with your exam syllabus, and this will be a huge boost for your preparation. Okay, coming to the live tests and quizzes. Okay, so again, whenever you're preparing for your entrance exam, you need to evaluate yourself. You need to know what is your weak areas and what are your strong areas. So this is possible only if you attend quizzes and tests. So here in Unacademy, there are regular live tests and quizzes happening, and this is how you can evaluate and analyze yourself better, and you can concentrate on the weaker subjects better. Next, coming to the unlimited access. So once you subscribe to the subscription, you get access to all the live classes. And even if you have missed the live class, you can go back and watch the recorded classes again and again. And all this in the comfort of your home, in the comfort of your own device. So I would highly recommend this platform. And using this platform in the beginning part of your preparation will be a huge boost for your preparation. These are the top educators in the platform. And all the 19 subjects required for your NEET PG preparation are taught in this platform. And these are the ongoing courses in our platform right now. Now coming to the NEET PG subscription package. So as you can see, the NEET PG subscription package varies from 1 month to 2 years. I would suggest the 1 year or the 2-year subscription. Okay, and for the ones who are writing their NEET PG 2021, for them the 6-month subscription would suffice. Okay, the 6-month subscription costs you 20,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 18,000. Okay, and the 12-month subscription. So for the interns, for the final year students, for the 3rd year students, the 1 year and the 2-year subscription will be very useful and will be very reasonable also. So the 1-year subscription is 25,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 22,500. And again, the 2-year subscription is 30,000. Using my code Shilpa 10, you get a 10% discount, and it will come up to 27,000. So I highly recommend this platform, and choose the package wisely, and yes, do your preparation for the exam. Okay. So now coming to today's topic, neonatal cholestasis. So very important thing is in newborns, jaundice is very common, right? In newborns, jaundice is very common. Okay, as there is physiological jaundice happening. Okay, so any jaundice, so unconjugated jaundice. So in physiological jaundice, it is unconjugated jaundice. So while in neonatal cholestasis, it is a conjugated hyperbilirubinemia, conjugated jaundice, conjugated hyperbilirubinemia. Okay, so any jaundice persisting beyond 2 weeks, beyond 2 weeks should be evaluated. Okay, so any jaundice persisting beyond 2 weeks should be evaluated. So in case of unconjugated jaundice, even the breast milk jaundice persists beyond 2 weeks, but it is not harmful. So it has a spontaneous remission, right? But a conjugated hyperbilirubinemia becomes very serious and troublesome if the child persists to have a conjugated hyperbilirubinemia beyond 2 weeks. It is serious and needs to be evaluated. So how do you say the child has conjugated hyperbilirubinemia? So if the bilirubin levels are less than 5 milligram per deciliter and the direct bilirubin is more than 1 milligram per deciliter, then it is called as conjugated hyperbilirubinemia. Or if the total bilirubin is more than 5 milligram per deciliter and the direct bilirubin is more than 20% of the total bilirubin, then it is called as conjugated hyperbilirubinemia. So if any of this is present, you have to evaluate for conjugated hyperbilirubinemia. Okay. So now in conjugated or the direct hyperbilirubinemia, what you see, so these children have high colored urine with or without acolic stool. So this urine is so much high colored that the diaper also gets stained. But while the staining of the diaper is very rare in unconjugated hyperbilirubinemia. Okay, so there is high colored urine with or without acolic stool. So here in neonatal cholestasis, a child who has direct hyperbilirubinemia, it is very important to refer the child at the right time to a tertiary setup where the expertise is very good. Okay, because these children most of the time might require surgery. You need to evaluate these, and the evaluation, you shouldn't be wasting time. Okay, so so you have to refer to a better center where the evaluation will be faster. And even if you evaluate and you can't do anything, any treatment, then you'll only waste time further. So instead, refer the child at the right time. Okay, especially in conditions like biliary atresia, it is a very serious condition if the management doesn't happen as soon as possible. Okay, so especially in these conditions with biliary atresia, the children are well and gaining weight. Okay, so because of that, the detection of the abnormality is not early, and the referral also gets delayed. Okay, but in conditions like um, metabolic liver diseases, these children have failure to thrive. Fine. Okay, so now coming to the clinical features. So as I've told you, first thing is the high colored urine. You have to know about, you have to check for high colored urine. High colored urine, and these children will have jaundice. Okay, and so another thing is, see since the sclera is lighter, I mean white in color, the jaundice is well seen in the sclera, but the parents again miss it because sclera is not always easily visible in a newborn. Okay, so parents might come late to you with the complaint that the child looks yellow. Okay, so it might be delayed. So this is a very important thing. So again, as I've told you, the biliary atresia, in case of biliary atresia, the child is well looking and gaining weight. In case of metabolic liver disease, these children have failure to gain weight or failure to thrive. Okay, so I've told you about acolic stools, right? So basically, what are acolic stools? So pale stool. So what happens is it's always better to check the stool in the center part. So cut the stool and see the center if it is pale or not. What happens is sometimes because of the intestinal bile pigment, the intestinal epithelial cells, this stool gets pigmented. That is why it's not a very good indicator to see the external pigment or external color for confirmation of the stool. So the center part is always better to check for an E. coli stool or the pale stool. Okay, so if there is presence of pale stool, what does it indicate? So it's not necessary always a pale stool means an extrahepatic or extrahepatic or an obstructive liver disease. Even certain metabolic liver disease, they'll have liver dysfunction and can present with pale stool. So one could be extrahepatic or obstructive liver disease. Next, metabolic liver disease. Okay, also there is an intrahepatic disease where the bile duct has bile duct has severe paucity. Okay, severe paucity, bile duct will have severe intrahepatic disease with paucity of the bile ducts. Next, also if the canalicular transporter is defected, I mean that if there is canalicular transporter dysfunction, also they can present with ecolic stools. But one thing you have to keep in mind, so in biliary atresia is an extrahepatic condition, right? So in biliary atresia, one thing you have to keep in mind is that these children will not have a persistent yellow color stool. Okay, so they might, the stool might be one, okay, persistent yellow color will not be there in a child with biliary atresia. Okay, so what are the other features you have to see? So these children can have signs of coagulopathy. So they can have signs of coagulopathy. So what is the signs of coagulopathy? So in newborns or in infants, these children can have intracranial bleed. Okay, so they can have intracranial bleed. Okay, they can have, because of this intracranial bleed, it can lead to seizures. The child can be irritable. There can be a bulging fontanelle. Fine. So these are the signs of coagulopathy. Okay. So if there is a neonatal cholestasis, these children can have hepatomegaly or hepatosplenomegaly. Okay. Next. So these children, they have features of early decompensation. So features of liver failure can be seen in these children. Okay. Features of liver failure. Okay. So now, especially in children who are sick looking, you should have a diagnosis of galactosemia. So sick looking children, so very lethargic, decreased urine output. They have the tired looking face, very irritable. Okay, such children, so sick looking children, you have to keep a doubt of. You have to think about galactosemia. Okay, tyrosinemia, hemochromatosis, herpes, sepsis. You should think about. Okay, so another thing again, it's well looking child with a direct component of hyperbilirubinemia. First thing you always think about biliary atresia. Now next, so these children, okay, another thing about galactosemia is these children will have E. coli sepsis, So they are highly predisposed to E. coli sepsis and cataract. Fine. In galactosemia. Okay. So if there is direct hyperbilirubinemia and there is rash, so I will write in the top section, I'll change the color. Okay. So there is direct hyperbilirubinemia with rash, like a maculopapular rash will be there. They'll have fever, there'll be chorioretinitis, microcephaly, lethargy. So by now you all should have come to the diagnosis. What am I talking about? These suggest certain intrauterine infections, congenital infections. So intrauterine infections, right? Okay. So there is another entity you should know, that is called the Allegiant Syndrome. Okay. So Allegiant Syndrome is another very important cause for neonatal cholestasis. So how do these? So these children have a typical allegeal face. So they have triangular face. Okay. They have a pointed chin. Okay. They have a very prominent ear. Prominent ears. Okay. They can have a cardiac defect. There's cardiac murmur. Okay. And the vertebrae in these children is like called a butterfly vertebrae. So, a child with direct hyperbilirubinemia present with such faces, you have to think of a familial cause, that a genetic cause, that is the Allegiant syndrome. Okay. Also, if there is splenohepatomegaly, so keep in mind now, splenohepatomegaly. So there is splenohepatomegaly, and you have a red cherry spot, a cherry red spot in the on fundus, cherry red spot on fundus. So what do you think? So that is a storage disorder. So you have to keep in mind. So this could be a storage disorder. Fine? Yeah. So the neonatal cholestasis, there are various causes. Okay. So we'll go to the causes now. So these are the various causes. So extrahepatic, there are extrahepatic disorders and intrahepatic disorders. So the extrahepatic disorders is what? Basically because of so something from the outside compressing or blocking the secretion of the bile. So generally, this choledochal cyst, inspissated bile duct syndrome, spontaneous perforation of the bile duct, biliary atresia. So all these are extrahepatic. While intrahepatic, there are the metabolic causes include galactosemia, tyrosinemia, okay, progressive familial intrahepatic cholestasis. This is also called as PFIC. PFIC. So there are two types, type 1 and type 2. So right now we are talking about the common causes. Okay. So progressive familial intrahepatic cholestasis, Niemann-Pick type C, mitochondrial hepatopathies. Okay. Fatty acid oxidation defect, bile acid synthetic defect, Zellweger syndrome, Wallman disease. Okay. Cystic fibrosis. Okay. Hereditary fructose intolerance. Now, infection. So what could be main thing you should think about? Torch infections or intrauterine infections, idiopathic. So most of the time neonatal hepatitis will have there will not be a specific cause. It's non-specific, idiopathic. Genetic causes is Allegiant syndrome, Down syndrome. Okay. Endocrine causes is hypopituitarism, hypothyroidism, anatomic. So what could be so if there is congenital hepatic fibrosis, Caroli disease. Okay. Others include neonatal hemochromatosis, total parenteral nutrition. Okay. So these are the causes, some of the important causes for neonatal cholestasis. Okay. We'll come back again after this entire class. Okay. So now when a child comes with when the child has prolonged jaundice, how do you evaluate these children? Okay. So first of all, what is your how do you diagnose? So first thing is a jaundice of more than 2 weeks, okay, and high colored urine. So a child comes. So just looking at the child's color, you cannot tell this is direct or indirect. So you get a total bilirubin and a direct bilirubin. So when you get a direct bilirubin, if the direct bilirubin is more than 20% of the total bilirubin, then you have to tag the child having cholestatic cholestasis, neonatal cholestasis. Okay, so next, so in these children you have to give vitamin K because the chance of bleeding is very high in these children. Okay, because yeah, so we should give vitamin K, give vitamin K. And this, and if the child is sick, so you have to check if the child is sick. So what did I say? If the child, how do you know the child is sick or not? So if the child has lethargy, if the child has bleeding, the child has hypoglycemia, seizures, if the child has edema, then you categorize the child as sick. So if the child is sick, then you have to think about what could be the possibility. So I told you in the previous slide, if the child is sick, think about galactosemia, tyrosinemia, hemochromatosis, right? So what are the possible causes? Galactosemia, tyrosinemia, neonatal hemochromatosis. Okay, there could be sepsis, severe UTI, congenital intrauterine infections. There could be congenital malaria or hypopituitarism. Okay, so these conditions you have to sick uh, if the child is sick. So if if the child is not sick, but you see that the child has pale stool, then what should you see? So if the child has pale stools or not, you have to check. So if the child has pale stool, then you have to think what are the possibilities you have to think about. So you have to think about biliary atresia, right? So you have to think about choledochal cyst, inspissated bile duct syndrome, Caroli disease, sclerosing cholangitis. So if these are diagnosed, then you have to get an ultrasound. Okay, so ultrasound should be done because these are the suspicion you have if the child has pale stool. So you get an ultrasound. So if there is ultrasound, in that you get either biliary atresia, choledochal cyst, or intrahepatic biliary dilatation. All this if it is there, then you go for surgery, especially surgery for choledochal cyst and biliary atresia. Okay, but it is not there. Other there is no biliary atresia and choledochal cyst. Then you get a serum gamma glutamyl. You get a serum GGT, gamma glutamyl transferase. Okay, you get a liver biopsy. Okay, and further workup is needed in these children. Okay, so once you get a specific cause, treat the cause, and supportive causes for supportive treatment for cholestasis should be done. Okay, okay, so now these pale stools are not there. So there is jaundice of more than 2 weeks, there is direct hyperbilirubinemia, but there is no pale stools. Then what should you think? So I'll write it on top. Okay, so I'll write it on top. So I'll change the color as well. Okay, so what could it be? It could be PFIC, that is progressive familial intrahepatic cholestasis. It could be paucity of the intrahepatic bile ducts, paucity of intrahepatic bile ducts. There could be cystic fibrosis. Okay, could be alpha 1 antitrypsin deficiency. Okay, it could be Niemann-Pick disease type 2, Niemann-Pick type 2. Okay, then it could be idiopathic neonatal cholestasis. Okay, so when this is there, again you have to get a serum gamma glutamyl transferase liver biopsy and confirm what is the diagnosis. So give a specific treatment for the specific etiology. Along with that, supportive therapy for cholestasis should be done. Okay, so in this also, these children patients should be workup should be done, and the specific treatment should be given. So this is how you evaluate a child with neonatal cholestasis. Okay, next, coming to specific management. So this okay, so general management. Okay, so what is the general management? So there is, for all these children with neonatal cholestasis, you have a supportive management which you have to do. So these children, you have to see that they take adequate amount of nutrition. Okay, so first thing is nutritional management. Okay, nutritional therapy. So so these children should get good amount of calorie. Okay, so they should get at least 120 to 150% of the RDA, recommended daily allowance of the calories. Okay, so this is the calorie. So these children, along with 120, they should get medium chain triglyceride supplementation, MCT, that is medium chain triglyceride supplementation. Okay, and breastfeeding should be continued. Okay, and these children, okay, need MCT. Why do they need MCT along with long chain fatty acids? So because these children, you should avoid deficiency of essential fatty acids. So along with MCT, you have to give long chain fatty acids. Okay, and also these children should be supplemented with all the vitamins, both fat soluble and water soluble vitamins. Okay, next, in children who have pruritus, so what is the drug you give for pruritus? So in children who have pruritus, you have to supplement with, you have to give ursodeoxycholic acid. Okay, so this helps deoxycholic acid. Okay, so along if ursodeoxycholic acid is not enough to control the pruritus, then you can try rifampicin. Then you can, or you can try cholestyramine. Okay, this is the first choice. First choice. Ursodeoxycholic acid is the first choice. Okay, so remember, for pruritus we give, especially in direct hyperbilirubinemia with pruritus, we give ursodeoxycholic acid. Next, thirdly, what you should do if there is any other complications of this liver disease, so you should manage the complications. So what are the complications? What are the complications? So you should know the main complications in these children are, they can have acute liver failure, right? So these children can go for hepatic encephalopathy, they can have severe ascites, they can bleed. So all this should be maintained, or this should be monitored. So I have done a class on hepatic encephalopathy, right? So you can check for the management there. So now coming to the specific management. So what is the specific management? You have to look here. So basically, if it is biliary atresia, what do you do? So what do you do in a child with biliary atresia? So you go for surgery, right? So in surgery, what is the name of the surgery for biliary atresia? Okay. So for the surgery, the name of the surgery is Kasai procedure. Kasai procedure. So this Kasai procedure should be done within two, within 2 months of life. That's 60 days of life. So if you do within 60 days of life, then the prognosis is good. Okay, if the surgery for biliary atresia is delayed, then the prognosis is not very good. Okay, so that is one thing you need to remember. And also children who have undergone Kasai procedure, but um, uh, they have features of end stage liver disease, or the bile is not draining out, there is the failure to drain the bile, then you have to go for liver transplantation. So uh, liver transplantation following surgery, following Kasai is done when? Done when there is failure to drain the bile, failure to drain the bile. And another thing is, even in spite of the surgery, the child goes for end stage liver disease. And liver transplantation is also done in conditions when when the diagnosis has been delayed, and surgery in this condition, this situation has poor prognosis, then also you can go for liver transplantation or delayed diagnosis. Okay, so you should remember here in biliary atresia, the main thing you have to remember is the name of the surgery, and by when if you do is a good prognosis. So if you do Kasai surgery before 60 days of life, then the prognosis is good. Fine. So next, so if the child has choledochosis, what do you do? So if the child has choledochosis, what do you do? So if the child has choledochosis, you excise the cyst and do hepaticojejunostomy. Okay. This plus to excise the cyst and do hepaticojejunostomy. Next, okay, this I'll tell you later. Next, thirdly, if there is herpes simplex, what do you do? What do you do in herpes simplex? So herpes simplex, the drug of choice is acyclovir. You give IV acyclovir. Okay, IV acyclovir is given. Next, if there is severe sepsis, bacterial sepsis, you give IV antibiotics based on what is the sensitivity of the NICO or the PICO and or the culture sensitivity. Okay. Next, if there is toxoplasmosis, what is the drug of choice which you give in kids? What do you do? So you give pyrimethamine and sulfadiazine, pyrimethamine and sulfadiazine with folic acid. Okay. And after 6 months of this thing, you have to give spiromycin also. Okay. This is a 1 year's treatment. So pyrimethamine and sulfadiazine. After 6 months, you start with spiromycin also. Next, if it is galactosemia, what do you do? So in child with galactosemia, you see that the child receives galactose-free diet. Okay. And then hemochromatosis. What do you do in case of hemochromatosis? In a child with hemochromatosis, what do you do? So you give IVIG, immunoglobulins, intravenous immunoglobulins. Okay. So this is about the management of neonatal cholestasis. So very important is, the first thing is the supportive management. You should remember This is very important. So the child's nutrition should be maintained. Child should receive 120 to 150% of the recommended daily allowance. Okay, and also the child should receive medium chain triglyceride supplementation, and the child should receive all the fat soluble and the water soluble vitamins. Okay, fine. This is what you have to remember. And yeah, so there is a picture of this child. So what is this child? So I was talking about the faces, right? So what do you see? There is a triangular faces. So there is a triangular faces with pointed chin, which has got prominent ears. Okay, so this is a child who is with we should diagnose as Allegiant Syndrome. Okay, this pointed chin is there, ears are prominent, triangle face. Okay, fine. So we'll do a quick revision. Okay, so we'll do a quick revision. Huh? Yeah. So first of all, what did I say? A child, any child who has jaundice of more than 2 weeks should be evaluated. First thing, and yeah, should be evaluated. Yeah, and a very important thing is you have to know that newborn jaundice is very common. So first thing you need to know, you have to differentiate between a conjugated and unconjugated jaundice. So most of the time, and always physiological jaundice is unconjugated jaundice. Whenever there is conjugated hyperbilirubinemia, and then you should diagnose it as neonatal cholestasis. Okay, whenever there is conjugated hyperbilirubinemia, it is a serious condition and it needs to be evaluated. Okay, so how do you say what is conjugated, how much is conjugated hyperbilirubinemia? So if any bilirubin, total bilirubin of less than 5 milligram per deciliter, then the direct bilirubin is more than 1 milligram per deciliter, then it is direct hyperbilirubinemia or conjugated hyperbilirubinemia. If the total bilirubin is more than 5 milligram per deciliter and the direct bilirubin is more than 20% of the total bilirubin, then it is again direct hyperbilirubinemia or conjugated hyperbilirubinemia. Okay, so these children can have high colored urine with or without ecolic stool. So ecolic stools is one feature of neonatal cholestasis. Okay, so not necessarily all the time they can have ecolic stools or pale stools. Okay, so yeah, so what are the clinical features? So one thing I said, they'll have jaundice, they'll have high colored urine. Okay, uh, yeah, so these children might not be even sick looking, especially in conditions like biliary atresia, in polydoculsis. They'll be well looking children and gaining weight also. Okay, they suddenly deteriorate later. Like they might have hepatic encephalopathy, they might have what is it? Coagulation defects, right? So that is why. So these children might get delayed, the diagnosis might be delayed in these children. But in children with metabolic liver diseases, they'll have failure to touch. The patients will come with a history of the child is not gaining weight. Okay. And also they can present with coagulopathy. So they could have intracranial bleed, which can eventually lead with seizures, irritability, bulging fontanelle. Okay. Hepatomegaly or hepatosplenomegaly can be present in these. Okay, there can be features of liver failure. Okay, these children can have ascites, they can have edema, they can have even hepatic encephalopathy. Okay, next, if a child is sick looking, what should you think? So a child with direct hyperbilirubinemia and looking sick, you should always think about galactosemia, tyrosinemia, hemochromatosis, herpes or sepsis. So especially in children with galactosemia, what speciality you see is these children have high chance of having E. coli sepsis. They have high chance of developing cataract. Okay. Also, these children can have pale stools. So pale stools are seen in which other conditions? One is it could be extrahepatic or obstructive cause of liver disease. It could be a metabolic liver disease, intrahepatic disease. Okay, with paucity of bile ducts. They can cause ecolic stools or pale stools. Okay, and if there is even canalicular transporter dysfunction, these children can have ecolic stools. Now, a child with direct bilirubin with rash, maculopapular rash comes with chorioretinitis, okay, with intracranial pathology. So, what should you think? So this could be a congenital infection or yeah, intrauterine infection, right? So next, there is a child who comes with who comes with direct hyperbilirubinemia and has a specific different face, I mean dysmorphic or a typical faces. What is this typical faces? So these children have triangular face, they'll have pointed chin, they'll have prominent ear. On cardiac evaluation, they'll have a cardiac murmur. The vertebra has a butterfly look, butterfly butt. That you have to think about Allegiant syndrome. Okay, so next, there is a child who comes with direct hyperbilirubinemia, with splenohepatomegaly, with a cherry red spot on fundus. What should you think? You should think of a storage disorder that time. Okay, so this is how these children present with various presentations. Okay, next. So now coming again the causes. So you should know these are you should know first of all neonatal cholestasis is divided into two, right? So extrahepatic and intrahepatic you should know. So extrahepatic causes are very few. So this you will know. One is biliary atresia, main thing. Extrahepatic biliary atresia. Secondly, choledochal cyst. Thirdly, inspissated bile duct syndrome. Fourth, the spontaneous perforation of the bile duct. Okay, so these are the causes for extrahepatic causes of neonatal cholestasis. Next, coming to intrahepatic. So metabolic causes. It could be galactosemia, tyrosinemia, right? Progressive familial intrahepatic cholestasis. So that is called as PFIC. There are two types, type 1 and type 2. Niemann-Pick disease, Niemann-Pick type C, mitochondrial hepatopathy, fatty acid oxidation defect, bile acid synthetic defect, cystic fibrosis, alpha-1 antitrypsin deficiency. Infections, you have to remember about the intrauterine infections, that for example, torch like toxoplasma, rubella, cytomegaloviral infections, herpes. So these infections can also cause congenital malaria. Okay, so they can cause liver dysfunction. Idiopathic. So what? So some of the neonatal hepatitis you cannot uh, find a cause. So they could be non-specific. So neonatal hepatitis. Genetic causes like Allegiant Syndrome. So this you have to remember. A genetic cause for neonatal cholestasis. Remember Allegiant Syndrome. Okay, Down syndrome. Endocrine causes hypopituitarism or hypothyroidism. Okay, anatomic abnormality. Because of anatomic abnormalities, what causes? So in intrahepatic or anatomic abnormality. So that could be congenital hepatic fibrosis, Caroli disease, neonatal hemochromatosis, total parental nutrition. Okay, so how do you evaluate a child who has neonatal cholestasis? So first thing, any child with the jaundice of 2 or more weeks, then with high colored urine, you have to evaluate. So in these child, you get a total bilirubin and a direct bilirubin. A direct bilirubin of more than 20% of the total bilirubin, then you tag this child of having neonatal cholestasis. You give this child vitamin K, and after that evaluate. So check the child. Is the child sick or not? So sick meaning the child being lethargy, child has edema, child has ascites, hypoglycemia. So the child might be sick looking. So if the child is sick, then what could be the causes? So it could be galactosemia, tyrosinemia, neonatal hemochromatosis. This child can have sepsis, severe UTI, torch infections, hypopituitarism, congenital malaria. So these are the causes you have to think in a sick child with direct hyperbilirubinemia or neonatal cholestasis. So you work up these child with all the liver function tests and other necessary investigations and give the specific treatment based on the positive tests. So next, if the child is not sick looking, you have to take the history of pale stools. So if the child has history of pale stools, then it could be biliary atresia, choledochal cyst, it could be Caroli disease, it could be sclerosing cholangitis. So this can be only diagnosed if you get an ultrasound. So right now, if you get an ultrasound, so what you, yeah, so ultrasound, you can diagnose biliary atresia or choledochal cyst. So how do you say this child has biliary atresia? So in biliary atresia, what happens is the gallbladder won't be visible. Okay, so when the gallbladder is not visible, it gives you a clue that this could be biliary atresia. So if the biliary atresia or choledochal cyst is diagnosed, then you go for surgery. For other causes, you have to get serum gamma glutamyl transferase, you have to get a liver biopsy. Okay, so that to confirm other diagnosis. So once the diagnosis is confirmed, you give all the supportive therapy for cholestasis along with the specific treatment for the etiology, right? Yeah. So now there is no pale stool. So what should you think? So there is a child with direct hyperbilirubinemia, okay, not sick looking, no pale stools, only direct hyperbilirubinemia. Then what should you think of? So they could be PFIC, that is the progressive familial intrahepatic cholestasis. There could be paucity of the intrahepatic bile ducts. There could be cystic fibrosis. There could be alpha 1 antitrypsin deficiency. It could be Niemann-Pick type 2 disease, or also idiopathic neonatal cholestasis can present like this. So in these children, again, you have to evaluate. So the various steps you have to do. So you get a serum gamma glutamyl transferase, you get a liver biopsy in these children. So once the etiology is found, get then do the supportive therapy treatment required for neonatal cholestasis and also the specific treatment for the etiology which has been diagnosed. Okay, so this is how you evaluate a child with neonatal cholestasis. Okay, so now coming to the management. So the child who has neonatal cholestasis, um, you have to divide in the treatment into two. One is the general or the supportive management. General or supportive. Supportive management. So that includes nutritional therapy, then management of pruritus, thirdly management of complications. So the nutrition therapy is what? So basically these children will require 120 to 150% of the RDA for calories. Okay, and these children should be supplemented with medium chain triglycerides. Okay, next, so breastfeeding should be continued in these children. Along with the medium chain triglycerides, these children should also be added long chain fatty acids so that you can avoid the so that you avoid deficiency of essential fatty acids. Okay, next, if these and also these children should be supplemented with fat soluble and water soluble vitamins. Water soluble vitamins should be double the RDA. Okay, next, pruritus. So if the child has pruritus, especially in obstructive cause, these children will have pruritus. So what do? So you have to give ursodeoxycholic acid. So this is very important. So a child with neonatal cholestasis and pruritus, you give ursodeoxycholic acid. And that is the first choice of therapy for pruritus. But you give ursodeoxycholic acid, but there is no improvement. There is prolonged pruritus. Then you can have a trial with rifampicin or cholestyramine. So remember rifampicin or cholestyramine. Next, the management of complications. So what are the complications these children can go? These can have ascites, they can have hepatic encephalopathy, these children can have severe bleeding. Okay, yeah, so these children have to be managed appropriately. So for hepatic encephalopathy, giving lactulose will help. Okay, so in severe bleeding, the children might need FFP, fresh frozen plasma. So the management of the complication should be done accordingly. Next, coming to the specific management. So what is specific? So specific management is once you come to know the etiology, you have to manage it accordingly. So along with the supportive management. So in case of biliary atresia, the therapy is surgery. So the surgery name is called Kasai procedure. Kasai procedure. So this is best has the best prognosis if it is done within 60 days of life. So 60 days of life. 60 days of life. So beyond that, if it is done, the prognosis is very bad. Okay. So once the surgery is done and still there is a failure to drain the bile, or if the child is going still into end stage liver disease, then the child has to go for liver transplantation. Okay. So, or also in a condition where the diagnosis is delayed, then the surgery will not be effective. That is why in such cases, again, liver transplantation is the treatment. Next, if there is choledochal cyst, what do you do? So you excise the cyst and you do hepaticojejunostomy. So you do hepaticojejunostomy in a child with choledochal cyst. Next, if it is a herpes simplex infection, what do you do? So if it is a herpes simplex infection, you important is the drug of choice is acyclovir. IV acyclovir is given. Okay. Also, in children who have sepsis, severe sepsis, IV antibiotics is given. So it is based on the first is you start on empirical treatment. So you should see that you should give antibiotics which are not hepatotoxic. Okay, it can worsen the condition. So you should see that which is the best antibiotic possible for this child and be given. So if the child has toxoplasmosis, so these children with toxoplasmosis will present with severe liver disease, there is hepatomegaly, there will be jaundice, there will be hydrocephalus. Okay, they have intracranial calcifications. So once you diagnose these children to have toxoplasmosis, you manage the child with pyrimethamine and sulfadiazine. So this is a 1 year long therapy. 1 year long treatment. So 6 months you give pyrimethamine and sulfadiazine, and after 6 months along with pyrimethamine and sulfadiazine you give pyrimycin. Okay. Next, coming to galactosemia. So what do you do in galactosemia? So these children, you have to see that child receives lactose free diet. Okay. Next, coming to hemochromatosis. The therapy is IVI. So each child should receive intravenous immunoglobulin. Okay, so this is you have to remember. So these are the main important causes and the management and the evaluation of a child with neonatal cholestasis. Okay. uh, yeah. Yeah, so I have told you, so this is a girl who has Allegiant syndrome. So she has a typical faces. There is a prominent chin. She's got prominent ears. The face appears triangular. Okay, so this is a child with Allegiant syndrome. Fine. So you have to remember this might come in your this thing, Allegiant syndrome. Right. So what did I say about Allegiant syndrome? So they have a triangular face. They have a triangular face. Triangular face. They have a prominent chin. Okay, prominent chin. Then they have prominent ears. It's prominent to pointed chin. Pointed chin. Prominent ears. Next what? So they have cardiac murmur. So what is the common what is one of the common cardiac defect you see in these children? So commonly you see these children to have pulmonary stenosis, PST. Sometimes these children will have the combination of these two and present with tetralogy of Fallot. Okay. Okay. Next, cardiac murmur over. Next, these have a butterfly vertebrae. Right? They have butterfly vertebrae. So what is the abnormality which happens over here? There is abnormality in the bile duct. So they have abnormality in the bile duct. So as a result, this causes liver damage. Okay. So this is about the child for Allegiant syndrome. So you have to keep this in mind. So first of all, this is because of the abnormality in the bile duct which causes liver damage, and these points, the typical phases of Allegiant should be kept in mind. And you have if there is a question based on cause of causes of genetic neonatal cholestasis, then the Allegiant syndrome comes first in the line. Okay, and next is progressive familial intrahepatic cholestasis. So all this should be kept in mind. Okay, so today's class is done. So tomorrow again at 1 p.m. I'll come with the quiz session on all the gastrointestinal disorders. So I have discussed a week long, I have discussed on all the gastrointestinal disorders in pediatrics, right? So tomorrow we'll have a quiz on the gastrointestinal system. Fine. So tomorrow at 10 p.m. here in the YouTube channel. Okay, it will be a live class. So today at 10 p.m. I will have a quiz on infectious disease. So infectious disease in the special class in the Unacademy app. So special class, I'm having a quiz on infectious disease. Okay, so it will be a revision. Okay, so attend the class at 10 p.m. today, and tomorrow go through all the topics for gastrointestinal disorders so that you can be more confident tomorrow in the quiz. So tomorrow I'll be having all the topics of gastrointestinal disorders. So very important thing is, so I always tell uh, yeah, one second. Yeah, so I've been always telling y'all it's very important to have a group discussion or like a discussion so that once you blot it out to someone, you'll be able to remember better. So that is one thing. Next, avoid social media. Okay, so that is very important. So you have to see that you have to save time. You cannot, waste time on social media. So once you get stuck to the social media, you'll be spending hours together on that. So avoid social media. Thirdly, have a good sleep. So sleep early, wake up early. This will help you to retain your the memory will be boosted better. Okay, so remember, so do all this. It will help you in your exam preparation better. Okay, and study daily. Reading daily is very important. You don't take a single day break. If you want to take a break, take study for 1 hour at least that day. But do not study. So if you do that, what happens that laziness will set in. Okay, so don't study every day and do not take regular breaks. Another very important thing, if you're when you're subscribing to the subscription, use my code Shilpa10. So tell your friends also, so use my code Shilpa10 and get the 10% discount on the subscription. Okay, so in the subscription there are various classes. Okay, so that is uh, accessible to only to the ones who have subscribed to the subscription. So there is various classes by various educators. So once you subscribe to the subscription, it's not that you have only my class. You get access to everyone's class, not just my class. So you get access to all the educators class. Okay, so subscribe to the subscription, use my code Shilpa10 and get a 10% discount. Okay, so fine, all the best, do well, study well, take care.